Thank you, Dr. Malika, for that excellent presentation. Next, I invite Dr. Smita for her talk on the mistakes in OCT evaluation.
Good afternoon, ladies and gentlemen. So, today I shall point out a few mistakes that we are likely to make during our interpretation of the OCT RNFL. So, today I shall be basically talking about the retinal nerve fiber layer and the ganglion cell and the ganglion cell layer, and OCT. Sorry. And OCT is the only instrument which can directly measure the thickness of these layers. So most of the other instruments were unable to measure it directly. OCT is the only one which can measure the thickness directly. So what are the pitfalls that we can encounter? So first is about the signal strength. So today, most of my printouts are of the Heidelberg because my hospital has a Heidelberg, and I have also incorporated a few Cirrus printouts. So it is important that we have the right signal strengths. So these are the signal strengths for each of the machines. For Spectralis, we need more than 15. For Cirrus, we need more than 6. And for Topcon, we need more than 60. So this is the place where the signal strength is given. So you can see that the signal strength is 31 in the printout in the right eye, and for 30 for the left eye. And in the Cirrus printout, it is only 6 in the right eye, which is just adequate. And for the left eye, it is 5, which is actually inadequate. So the conditions, like say having a dirty lens or a dry eye or the presence of cataract, and even paradoxically, a posterior chamber IOL can decrease the signal strength and therefore decrease the quality of your OCT RNFL. So these have to be looked for, and these can cause mistakes in your OCT RNFL assessment. So what does a poor signal strength lead to? A poor signal strength is best seen by a poor. Can you tell me how to use this? Okay, if you look at this area does not show the details of the blood vessels, the finer blood vessels. It is dark. So when you look at this position, that this is a temporal part, the temporal part appears dark red over here. So even though we do not need the temporal portion in the management of glaucoma, you can see that poor signal strength, which has led to a grainy B scan, has led to the poor delineation of the blood vessels in this area, has led paradoxically to a thinner OCT RNFL in this area. So this thinner OCT RNFL, you have to remember, is because of poor signal strength. So do not take OCTs which have poor signal strength, discard them. Another important factor to be looked for is decentration of the measurement ring. This measurement ring center should coincide with the center of the optic disc. This is a decentered ring which has been exaggeratingly decentered. So you will find that in the Tisnit profile, everything appears very abnormal, and also some of it is supra thick. But when it is centered properly, you can see that now the contour and the thickness appear normal. So second mistake you can have is a decentration. More than 10% decentration in any direction will lead to abnormalities in the measurement of the RNFL. So over here you can see that this portion, you know about the ISNT rule. In most of the patients, the inferior rim is the thickest, next is the superior, then the nasal and the temporal. If this measurement ring moves superiorly, then it means that you are going to measure a thicker area inferiorly as compared to a thinner area superiorly. So there is a higher chance of violation of the ISNT rule. So sorry. So decentration is a very important thing to be looked for. So first is you look at the signal strength, and second is you look at the centration of the ring. Immediately after appropriately positioning the ring properly, you look at the structures under the ring. Under the ring. So over here you can see a black area. So this black area will prevent the acquisition of the scan in that position. So this is corresponding to this position, and you will find that the scan is not taken appropriately, or there is a thinning in that area. So when you look at the measurement ring and you look at the position of the black area, which is actually a floater. So when this floater has moved away from the circle of measurement, then the scan is okay. But if this floater under the circle of measurement prevents the acquisition of an accurate scan. So that is the third mistake that you have to avoid. That's the third pitfall that you have to avoid. In this cirrus printout, you can see a floater which is abutting on the deviation map. In this deviation map, you can see it is abutting on the measurement ring, and that is why you see in the infratemporal portion there is a thinning in the thinning in the Tisnet profile or in the measurement circles. Motion artifacts, they are basically now rare because the instruments have incorporated correcting features to it. But in cirrus, you can identify it by looking at the blood vessels. So if you find that the blood vessels are cut and there is a horizontal line like this, then it indicates that there is a motion artifact, and so such a printout should be discarded. Cut edge artifacts happen more in places where student technicians are working. So they are likely to take a printout where the details in the edges of the OCT are not available. So the cut edge artifacts are, so such printouts are usually the first ones that are taken, and therefore they also have to be discarded. So this is a cut edge artifact which shows a red color in the edge. So this is basically not only seen in when a printout is being taken by, when an OCT scan is being taken by a technician, it is also seen when you have patients who cannot sit properly. So like say in a high myope, very high myope, it is difficult to take an OCT scan, and that can give you a cut edge artifact. Misidentification of the RNFL can happen, and so you have to look at the screen. So that screen may show so see here, there was some failure of algorithm which led to a misidentification. So when the scan was repeated, then the contour and the thickness became almost corrected. So that it is very important, if we can see the screen and look at the red line which indicates the inner limiting membrane and also the outer portion of the RNFL, you have to look at their position and therefore identify the failure of the algorithm. Sometimes PVD can cause a traction, and this traction can cause a thickness of the RNFL measurement which actually is not there. So a serial follow-up will actually, when this traction is released, this can collapse and you might think that the RNFL has thinned down. So serial follow-up should allow you to look at these structures to know which portions are being measured, and so therefore it is very important that we look at the B scan of the patient to identify these conditions. Posterior misidentification of RNFL is a less common condition. Over here, a large blood vessel has caused a failure of the algorithm. You see this area is also dark, and this blood vessel, which is identified over here, has caused a failure of algorithm. So the machine is measuring a sort of a guesswork. A machine is doing a sort of guesswork, and you find that this area is very much thickened. So it is like a supranormal thickness. So again, identification of this area on the screen of the machine is very important. Floor effect, I think by now almost everybody knows what is the floor effect and what is the parameter to be taken for each machine to be considered as floor effect. So for spectralis it is 49.2 and for cirrus it is 57 microns. For RT-view it is 64.7. It means that there has to be some amount of tissue including the blood vessels and the glial cells which are not destroyed even though the glaucoma has come to an advanced state. So if you have the Tisnet profile showing that this line or this actual measurement of the patient is touching the floor, then this has to be reworked, remeasured. This I've already discussed. Green disease means that the person is classified in the RNFL as not having the disease, even though you see that there is an RNFL defect over here. By the way, RNFL defects are best identified from fundus pictures as compared to our own examination, and you can see that even though there is an RNFL defect, this appears green. So in this case, we are missing a diagnosis of we are missing a diagnosis of glaucoma, or we are missing a proper examination where this patient needs a more thorough examination. There are many instances where normative database is not available. PGI Chandigarh is actually working on smaller children and giving us a normative database for Indian eyes. In instances where normative database is not available, we have to go for the macular parameters. This is the normal RNFL thickness for the Indian eyes, which is about 8 to 12 microns thinner than the Caucasian eyes. And since our reference is the European database, we have to keep that also in mind and prevent a mistake of labeling a patient as glaucomatous. So the red disease where we label a patient as glaucomatous leads not only to an unnecessary diagnosis, it also leads to unnecessary treatment and the side effects of those treatment, and also to unnecessary litigation. Now, this is a very, very rare instance. I personally have not seen such a case. This is from the literature where you have a split RNFL. You can see the split over here, which is a normal anatomical manifestation, which leads to thinking that this might be a notch or leading to a glaucoma. And this also causes a lateral shift of the RNFL bundles. Again, this patient is more likely to be labeled as normal. The risk factors for creating the artifacts which may cause us to mistake it as glaucoma are poor visual acuity, cataract, and advanced glaucoma. So my take-home message is, in order to prevent the diagnosis, never base your diagnosis solely on the OCT. Spend time on examination of the optic disc and correlate the findings with the disc, and look for the signal strength and decentration. Thank you very much.
Very correctly said take home message. Thank you, Dr. Smita, for that very simple and very meticulously presented.